Our next presenter is Dr. Enrique Alvarez. Dr. Alvarez is the Vice Chair of Clinical Research and an Associate Professor at the CU School of Medicine, Department of Neurology. Dr. Alvarez is presenting on hot topics in MS, including a COVID-19 update, the Epstein-Barr virus study, and biomarkers.
Perfect. Well, welcome everybody. It's great to see everybody wearing masks, or not wearing masks. Sorry, actually seeing faces. This is awesome. So I got three kind of random topics, so I apologize for that. So it will be a little bit of a busy presentation. There's going to be a lot of slides that I'm really going to just kind of blow over that just make a quick point about something. So don't expect to kind of be able to follow the slide, just kind of mostly listen and take back some of the concept. The slides will be there, so if you want to go back and get all the details, they're there for you for that. So this first part, talk about COVID. Kind of, you guys have heard me do a lot of these, and so I want to blow through this really quick so that we could talk a little bit about Epstein-Barr virus and then about neurofilament light as an example of a biomarker, and kind of how do we bring biomarkers to life? What are some of the things that we look at? Are we ready for neurofilament light as a marker? All right, so where are the numbers? We could see that, numbers are really low right now. Where are we going? We can see that we're looking at over the winter months having a wave that's probably going to look about the same as our summer wave as it came about. So not a huge peak as we saw in the past. We're still dealing with the COVID variant BA.5 of Omicron. You can see that in sort of this part of the slide here. There is some inkling of BF7, kind of the latest bad boy in town. But this is not really making much of an inroads and seems to be mostly being keeping at bay. There is kind of one of the older ones, so the variant of BA4.6 and kind of the darker brown color that's making a little bit of kind of steady, not going away, not coming back. So we'll see what it goes. But the good news is that this is the variant for which now we have the new bivalent booster to. And so when we talk about getting vaccines, this is much better to get it for kind of, again, this strain. Unfortunately, the bivalent means we're still getting vaccinated for this stuff here too, which I'm not sure why, but it is what it is. And so we'll take it as well. This same slide I've presented multiple times, and just to kind of highlight, and I think Dr. Schreiner kind of went through a lot of these things already. So age becomes an issue, male gender, all these things kind of increase MS risk by 2 to 3-fold. Disability level is the one that I really am concerned about. If we look at, and I'll talk about treatments, at data from like COVIMS, the North American Registry for COVID, we can see that most of these things increase risk 2 to 3-fold, but when we look at disability being non-ambulatory, increases your risk by 25-fold. So it's a much bigger risk factor than it is for other things. So as you're looking at things like Dr. Schreiner was mentioning, these are the things that I also look at in addition to some of those things. When you look at treatment as far as death in this column, there's not much of a change with any of these. The statistical value for these are pretty small. When you do look at hospitalization, B-cell depleting therapies and Ocrevus and rituximab do still have a little bit of a role of increasing the chances that you end up in the hospital with that. So again, these are the reasons why on these drugs, and I would include S1P, so things like Gilenya, predominantly in that category, but also siponimod, ozanimod, and ponesimod in that category, where I would consider patients to be immunosuppressed and looking at vaccine responses. So what to do? We heard a lot about social distancing, vaccinations, and monoclonal antibodies. These clump up the virus and don't let you infect and don't let it infect you. The monoclonal antibodies that are preventative, Evusheld, we'll talk a little bit about, but also from a treatment perspective, are one of the things that we didn't have at the beginning of the pandemic. As far as vaccination guidelines, again, most of this is the stuff that we had in the past. I highlight a little bit because I still see this a lot in clinic, that when we talk about sort of the initial series, that we are talking for the most part 2 shots, 1 shot, this kind of stuff. If you are on B cell depleting therapies or S1P drugs, um, that we are really talking about having an additional dose to kind of help boost that immune system, not technically a booster, but an additional dose that kind of goes with that. And so, predominantly with Pfizer and Moderna, that 3 shots is the initial vaccination boosters. I mean, again, if you're talking 3 shots here, 2 boosters, and now the new bivalent, I don't know that I can recommend that many shots. But I do recommend that if you were lagging a little bit behind on boosters in the past, that you consider getting the bivalent booster because, again, that's the stuff that's out there. And it's much better than trying to get something that was out there 3 years ago. So this is good. Timing, we talked about getting the flu shot soon, but maybe waiting to get your COVID booster around infusions if you're on an infusible therapy. If not, it doesn't matter that much. The reason for that, we'll talk about in the next slide or two, as far as timing for COVID. But the idea is you've had exposure from some of the other vaccines. If you wait 6 months to get the flu vaccine, you're going to miss the flu season. So there is no point then in getting it in 6 months. So that's why there's a little bit of a difference in rationale as to why we say get the flu one now and maybe wait to get your COVID vaccine. So this is one of the bigger studies, one of the nicer studies that was done. I've shown you this before again, but to highlight a lot of these patients on B-cell depleting therapies and healthies were able to develop good antibody responses. On B-cell therapies, this was about a 50% chance that you did. This was actually higher than in a lot of other studies. And the difference between these patients and these patients is that their B cells predominantly were back by the time they got vaccinated. We can fix some of this stuff with Evusheld and monoclonal antibodies. But the other important part of vaccination is to get the T cell responses, and we can see that that's pretty much 100%. So who can get Evusheld? A lot of stuff, but predominantly for us, it's immunocompromised patients, and again, predominantly B-cell depleting patients and those on S1P inhibitors. Evusheld is this preventative monoclonal antibody. It's 2 shots, and you have to be watched for an hour. There are some risks. Predominantly, you don't want to get this in the first 2 weeks after getting a COVID vaccination because your immune system is going to be kind of reacting to it. These other things are really minor and should not be an issue if you're already getting our disease-modifying therapies, especially infusibles, because there are mostly risks associated with getting antibodies. As far as treatments and monoclonal, so again, these are if you're sick, these are the ones you can get, as opposed to the other ones that are preventative and that you can get every 6 months. We still have this one that's still effective. These have fallen off because they're, again, older strains that don't work against the variant that's out there now. You can still get convalescent plasma. We think about this as sort of being one of the 3 main treatments that we can look at for COVID, with the other one being remdesivir and Paxlovid. All 3 of these are fairly similar. Some countries, and although you can still get it in the US, we don't use it as much. It doesn't work quite as well. It does have a little bit of a track record because it's approved in some countries as an antiviral, and I forget against what. But because we have better treatments, pick one of the better treatments and kind of go with that. So I think from that perspective, we have treatments, we can preventive, and this was kind of putting it into a math equation, what Terry just basically brought up. So kind of looking at what the rates of COVID are. This is a fluctuating number. How much spit are you sharing? So indoors, outdoors, number of people, mass, time, all these other factors that kind of go with it, as pleasant as that thought might be. And then what is your susceptibility? And this is drugs, comorbidities, and factors such as that. So not that you're going to come up with an exact number and be very specific about it, but it kind of gives you a sense for how careful should you be about wearing masks, distancing, going to those concerts, as Dr. Schreiner brought up. I think because of where we're at and all the treatments, again, this balance between risk of COVID and mental well-being should now be favoring heavily the mental well-being. And so trying to kind of do all the things that keep us mentally healthy becomes very important. And so that allows us to get out and exercise and do other things as well. All right, so we'll talk a little bit about Epstein-Barr virus. So my connection here is just that it's another virus. COVID is an RNA virus versus Epstein-Barr virus is a double-stranded DNA virus. So very different type of virus from coronavirus. This made the news a lot because of this paper. to be honest, this paper didn't add that much to a lot of their prior work that was already that they'd already shown. They'd shown a lot of linkages already between MS and other groups had as well. But it was kind of a nice summary of a lot of their work. And I think it was kind of a nice paper to kind of go through, but it's definitely brought up a lot of questions. So Epstein-Barr is a herpes virus. So there's oral herpes, genital herpes, the shingles virus, so zoster, CMV. All these are some of the other herpes viruses that are out there. These are very common viruses. They're best known for causing mono. If you get it as a kid, you probably don't even know that you got it. Doesn't produce much of any kind of illness or anything like that. But if you get it as an older, then you get the kissing disease or mono. Epstein-Barr virus, one of the cells that infects are B cells. It can cause cancers of those B cells. And so it's linked with things like Burkitt's and Hodgkin's lymphomas, for example. And curiously, we just talked about B cell depleting therapies working in MS. And so maybe some of the effect might be on taking out B cells. So what was the link with this paper? So they took in this study samples from over 10 million people that are in the military. And they restricted it down to people who had 3 samples. They also had to restrict the number of patients a ton from that 10 million because 94% of healthy people already have Epstein-Barr virus. So this is how common it is. That number jumps up to about 99% of patients with MS. And I'm sure that if they put a decimal point, it might be like 99.9%. But that's kind of the numbers that we're looking at. When you look at this, what they notice is if you look at people who were Epstein-Barr virus negative, and then they followed people, their chances of developing MS were much higher if you had Epstein-Barr virus versus those that did not get Epstein-Barr virus. You can see that versus those that did not develop MS. And so they had 33 patients who developed MS, and 32 of those were positive for Epstein-Barr virus. So it was almost 100% as far as that goes. This was an increase of 32-fold. That increase was not seen with CMV, again, another one of these herpes viruses that spread similarly to Epstein-Barr virus. This increase pales as 10 times as higher as what we see with our highest gene that we associate with MS, which only causes an increase of about 3-fold. So this seems like a really kind of strong evidence to be associated with MS and maybe triggering that response to MS. So what else did they look at? And just to kind of foreshadow the last little bit with neurofilament light. Neurofilament light is a marker of neuron damage. And here you can see the spike in nerve damage that you see in these patients. So before they develop MS, around the time of infection, and after they develop MS, you can see this big increase of about 60% higher levels of neurofilament light. You don't see that in patients who don't develop MS. Looks awesome, right? Let's look at the data a little bit, and we can see some of the problems that come up with biomarker work. So this is the actual data. All these little time points are the individual patients at the different 3 time points for those that have MS in green, blue for those that don't have MS. And you can see that, yes, the mean goes up, the average goes up quite a bit. It goes up that 60% that we saw in the other graph. But you can see that it's mostly driven by 3 people whose numbers increased by like 10 times. And so these numbers are kind of pushing up the average by a lot. When you look at sort of what normal is for neurofilament light, and again, this is a tricky number to kind of really develop, as I'll describe a little bit later next. A lot of times one of the numbers we use is about 20. So really only 3 patients, there's actually 2 tiny dots right there, who have high levels of neurofilament light, and one of them had it even before they developed MS. So at the population level, these things look great. At the individual level, this may not be a great marker. And we'll talk about more about this a little bit later, as I said. All right, so they took these samples and they said, hey, what were their responses to other viruses to kind of show that the effect was really an Epstein-Barr association and not to just CMV or Epstein-Barr. And this was kind of the main thing that they added in this paper. You can see all these different viruses that they looked at. And you can see that there's one that really stands out, and that's Epstein-Barr virus. In this color, it tells you that there's a suggestion of higher cases who develop MS versus those that don't develop MS. So for a lot of the other viruses, you can see that it's higher in controls or people that don't develop MS, but for the most part, it really stands out, this association with Epstein-Barr virus. All right, great. So how does having Epstein-Barr virus lead to MS? Well, about a week and a half after that first paper, there was this other paper that I think is actually maybe a little bit more interesting. But this came out of the Stanford group. And what they did was they took those antibodies that we often look at in spinal fluid, those oligoclonal bands, and they said, hey, what do these antibodies react to? And they found that about a third of patients had antibodies that reacted against Epstein-Barr virus. How specific is that? Well, about 20% still had antibodies that reacted to other viruses. And to show that this is a family of viruses and they kind of look the same, kind of like human families look the same sometimes, they found that about half of antibodies that recognize the zoster virus, the shingles virus, they also bind the Epstein-Barr virus. So there's a lot of similarities between these viruses. So is it specifically Epstein-Barr, or maybe it's an association with some of these other viruses that are in that herpes virus? It's a little bit maybe harder to kind of discern. When we look at this, they took 9 patients and they said 6 of them had antibodies to the full length of the Epstein-Barr NA1 protein. So this is one of the proteins that's in these viruses. These viruses will have usually tens of different proteins. They're very simple. If you look at little pieces of that protein, 8 out of 9 actually bound to some part of that protein. So this seems to be like an important area, but we already knew that Epstein-Barr, this EBNA1, is an area that MS patients tend to make antibodies to. So they found one antibody that really bound to this region. This is the protein. This is the different amino acids that make up that protein. The bigger the letter, the more that antibody is important for the binding of the antibody to that protein. And they took this antibody and they said, what else does this bind within humans? And what they found out was there was a strong link with that antibody that it could pick out this other protein in humans called glial cell adhesion molecule, or glial CAM. So this is a protein on the surface of cells that are glia, the supporting cells in the brain. And if you overlay the 2 proteins, you can see that over these big amino acids that are important for the binding of the antibody, that they're identical between the 2 proteins. So it could be that these antibodies to Epstein-Barr kind of start triggering a reaction. We call this molecular mimicry because this other protein kind of looks the same. It gets confused. It kind of looks like it. Racial profiling, if you would. And then you have 20 to 25% of MS patients in 3 big groups that they looked at where they had antibodies that could bind this Epstein-Barr, NA1, and glial CAM proteins. This number might not seem really high, but we got to remember that antibody levels go up and they go down. So whenever these were tested, that was 20 to 25%. It's possible that these numbers might have been much higher if you catch it at certain times, like right before they develop MS or things like that. To go back to that original study in the military patients, if they look at the different proteins that people were making antibodies to of Epstein-Barr virus, it's predominantly to the EBNA1 protein. So that appears to be the target. And if you then, to go back to the Stanford paper, if you take that protein and you put it into a mouse model of MS, in red, you can see that the scores of disease activity, how bad the mice does with their mouse MS, is actually worse than the mice who just were part of the model. So it's kind of starting to provide a little bit of a link as to what this Epstein-Barr virus might be doing. And again, maybe some of the other viruses in the herpes family that might kind of cross-react and kind of trigger this reaction for MS. So what can we do about it? We might be able to vaccinate against the monovirus, and that's one strategy that's being done. Maybe by the time you have MS, it might be a little bit too late. So one other strategy, and Atera, one of the companies called Atera, is developing this ATA188. They just are wrapping up their phase 2 in BOLD study. And this are T cells. You actually get a cell therapy, these T cells that can bind B cells that are specifically infected with Epstein-Barr virus. So instead of taking out all B cells, you're just taking out the B cells that are infected with Epstein-Barr virus. So it might be a very specific way to kind of target the strategy, and so kind of a cool strategy of trying to kind of see what can we do about it. This was a hard study to recruit for. We got a whopping one patient because it involved multiple spinal taps, at least three, with many, many visits and that kind of stuff. So again, we're thankful for patients who participate in studies because they can get really involved. All right, so go back to biomarkers and neurofilament light. I kind of gave you a taster that maybe it's an okay marker, but not a great marker. So what can we use it for? What are biomarkers, I guess, first? So, sometimes we think about it specifically as things that you have to measure in spinal fluid or blood or things like this and kind of, be a little bit more invasive. But the reality is we use biomarkers in MS care all the time. So we use biomarkers as far as MRIs go, and the lesions, T2 lesions, contrast enhancing lesions. We can look at atrophy. Our disability scales as a biomarker. We can use patient-reported outcomes and things like this as well. One of the things I like to note is that by the time you measure things in blood, and this will be a theme towards the end of this chunk, is that how fast can we measure something? So again, nerves aren't breaking down in blood because that's not where the nerves are. They're breaking down up here, and those proteins have to make it into the spinal fluid. Then they have to get absorbed and crossed over into the blood. And so that's going to take some time. How long does it take? I'll show you here in a little bit. All right, so neurofilaments come in different flavors. These are the proteins that kind of give structure to nerves. And so when the nerve breaks, they release these chemicals inside of them. There's different types. There's neurofilament light, medium, and heavy. And they don't match up. So neurofilament light and neurofilament heavy don't correlate to each other. So as one goes up or down, the other one may not necessarily go up or down. So even though they're in the same place, they don't match up that well. Maybe one can get into the blood faster, maybe one sticks around for a really long time, or whatever reasons. And some of the studies I was involved early, we showed that neurofilament light goes down with rituximab really pretty well, but neurofilament heavy, for example, does not. Neurofilament heavy correlates better with disability. Neurofilament light correlates better with inflammation, with like contrast enhancing lesions. So knowing what you're trying to measure and how much of that marker tells you about is really important. One of the things that this became a hot topic was there's very little of that protein that makes it into blood. And it's this technology that I'm not going to get into, but that allows us to really measure those really tiny levels that make it in blood. This allows us about a 50-fold better sensitivity. Like we can detect levels that are a 50th the level in blood that we used to be able to do using ELISAs, the old technology for measuring this, and the stuff that I was involved with a little bit earlier. And this is something that we have the ability to do on a research basis here. So how well do blood levels account for spinal fluid levels of neurofilament light? You look at the pictures, it looks great. The higher the one, the higher the other one. When you look at how much numerically, this is the number we care about. This tells us that about 55% of the blood levels is probably gives us a sense for how much can explain the levels in spinal fluid. So if, meaning there's 45% in this case of other factors that explain what the levels in blood are. So it's okay. It gives us a measure of what the spinal fluid levels are, which is really what we probably care about the more. But there's other things that apparently affect blood levels beyond just the concentrations in spinal fluid. So what are some of those other factors? I'll get that in a second. So what can we use NFL for from a diagnosis perspective? So this might be a good marker for nerve damage. So maybe we can use it for relapse versus pseudo relapse. We can monitor patients on their treatment. We can predict how much damage you're going to have after a relapse, prognosis type stuff. Levels go up in PML. So it's the problem with this is that it's not specific to MS. Anything that causes damage to nerves increases levels of neurofilament light. Many things can then affect levels in blood. The stuff in red basically means that any of these things increase the levels in blood. The blue stuff decreases the levels of blood. So anything that causes damage, for example, peripheral nerve damage, even like diabetic neuropathies, can cause increased levels of neurofilament light. One of the big ones we'll talk about is BMI or weight. And we were expecting that, usually people who are bigger don't do as well. But one of the things that we find out is it actually reduces the levels of neurofilament light. Aging becomes a very important one. So this was early work. If you pick the percentile, you can go down any column you want. Look at a 30-year-old versus a 70-year-old. You can see that the levels increase almost 2.5-fold and still be in the same range as what you would expect for that age. So age is one of those things that doesn't make that correlation between blood and spinal fluid 100%. Because the older you are, it's normal to have levels of neurofilament that go higher. And that could be that doesn't necessarily mean more damage. It could be simply that the blood-brain barriers decrease, that the chances of that protein making it from the brain to the blood is a little bit better. And we don't know what accounts for that. When you look at progressive patients, so this was 2 different trials. One was a progressive, one was a relapsing study. The progressive patients had a little bit higher levels than the relapsing patients. So what type of MS seems to affect what type are your levels of neurofilament light. We can see the same age effect in one of our studies. We can see that very few patients actually had high levels. This was patients treated with rituximab. As we looked at BMI, looking at that effect that we were thinking that we would see, that patients that were bigger would have higher levels of NFL because of comorbidities, we actually found out the opposite. It was all the skinny, small people that had higher levels of neurofilament light. And now we're starting to realize that that's probably just dilution. People have more blood in them, and so they just dilute out that protein that's being made all in the brain. And it provides some weird things, like patients who on B-cell drugs are fully depleted actually have higher levels of neurofilament light than people who are not depleting well. Because people who are bigger also don't deplete as well. And so that's why we see some of these differences. So again, having to explain this stuff is a little bit harder. And now there's a calculator you can go to online as of this year, where you can kind of try to match up for weight and age to try and say this is a normal level for somebody who's a 20-year-old with a BMI of 25 versus somebody else. And we're not seeing a lot of this yet in use, but this is kind of some of the things we need to do. So we were complaining a little bit about correlations. These R-squareds about 55%. We can see that when we look at baseline neurofilament light levels and what they allow us to kind of correlate with within a study, they looked at a number of different things. All of these were statistically very significant, but how much do they explain and actually go with that? So if you look at disease duration with levels of neurofilament light, it explains 1% of the levels of neurofilament light. Doesn't explain much of anything. The best one was number of contrast enhancing lesions, and that was 11%. So the number of contrast enhancing lesions explains 11% of your NFL levels. Again, that's the best that we have, but again, it tells us that it's probably a better marker for inflammation than it might be with disability as measured by the EDSS scale, cognition as measured with SDMT, and things like that. How fast do these numbers drop? So these are a couple different studies looking at a couple different drugs, and we can see that it takes about 6 months for those levels to drop in 2 different studies, with some decreases still kind of extending past that. Depending on the drug, interference, it might take a full year as opposed to the 6 months on Genentech. If you look at patients with enhancing lesions and those without, because that was our best correlation, we can actually see that the levels increase in the first 3 months of treatment. Again, it's probably because it's taking a while for that neurofilament light to make it from brain to blood. And then in this study, it took almost 2 years for those levels to drop. So if you're using this as like trying to kind of see how fast these levels are going to respond to your treatment, you might be waiting around a long time. If you don't have contrast-enhanced lesions, there's really not much change in those neurofilament light levels. So it's not providing much benefit. So here we can see a big difference, the levels increasing, and that might take us 2 years. Here's another study to kind of look and say, was that just something with that drug? These are with the Ocrevus studies, with the relapsing studies, and then the primary progressive trials. Here we can see it's taking 2 years for those levels, or at least a year and a half for those levels to drop. In the progressive studies, we don't see as big of a drops, again, saying that this is probably related more to inflammation than it is with progression. If you look at split the progressive study patients into those that have enhancing lesions versus those that don't, most of the changes are with those that have enhancing lesions versus those that don't. It takes, again, a long time. Do we get close to normal? This is normal. There's a little bit different as to how you measure it between different types of blood tubes. When you go in and get blood tubes, right, you get the purple tops, you get the red tops. That matters. Those concentrations actually change a little bit, the levels of that neurofilament light protein. So it takes a couple years, maybe a year and a half for neurofilament levels to get to baseline, versus MRIs takes us basically 8 weeks and you already have a better measure. So MRIs might suck, they take a long time, but it appears that from a time perspective, they give us a better readout than neurofilament light levels do. It's not just blood. When we look at levels in spinal fluid, we can see that at 12 weeks, 24 weeks, and 52 weeks, that we're still seeing further and further decreases of 25%, 40, and 55%. How long do the levels take to go up? It's not very fast. If we look at stroke, which happens sort of like instantaneous, right? We can see that levels gradually increase, and those levels may continue to increase even 7 days after that event. So if you're starting to develop new symptoms of MS, it may take a long time for that neurofilament light level to actually increase in blood for us to be able to measure it as a marker for that. And again, great at population level, but this is kind of what it looks like at the patient level. And so if you look at this, in this patient, this symbol means that that MRI had new lesions. We can see that neurofilament light levels at that point were normal. And it took until 4 weeks later to be able to actually pick up that difference in neurofilament light levels. So it's not happening fast. It's taking a while just for measuring that. If you do serial blood draws, only this one would actually pick up the change in neurofilament light. Versus an MRI is a good measure to say you had something that happened in the past time since your last MRI, and gives us a better picture as to what actually happened during that time. You can end up with very complicated algorithms, such as something like this. To highlight this, this includes having to do NFL monitoring every 3 months. I know you guys like to come and see us in clinic and get blood work all the time, but I'm hoping to not have you guys do that. And so trying to push you out to every 6 months or farther if we could, to do that. And so I'm not sure how pleasing some of these strategies might be for that. So I'll skip some of those things and turn it down for our break at this time. Thanks.